Welcome to Perspectives in Peds, or PIP for short, your go-to podcast for insights into paediatric practice. From clinical approaches and emerging research to the everyday wins and challenges, we bring you OT perspectives that inform, inspire and spark conversation.
Welcome back to Pipcast. Today we're joined by Mikayla and Caitlyn Cowie, and we're chatting about therapy planning. It might sound a little bit dry, but we actually find this topic weirdly interesting. It consumes a lot of what we talk about at the clinic, and I think the main reason we wanted to chat about it is because we just feel so passionate about how it just anchors our therapy, and we should be therapy planning effectively. And we also, I guess, we conduct a lot of supervision, both internally and externally, and we often hear therapists that are just lost with direction and where to go. And when we bring it back to their goal and how they're approaching therapy, we can often get a lot of really good nuggets and direction from chatting a bit further about it. So I guess we would start by kicking off. Does someone want to explain, from when we're talking about therapy planning, what that actually is?
Yeah, so a therapy plan is a block of sessions that might be one term, 8 weeks. Just think about, wherever you practice, you probably work in some form of block. So it's a block of sessions, and what the therapy plan includes is an outline of how we're going to meet what we're working toward. So we will talk about long-term and short-term goals in a second, but a therapy plan is based on the chosen priority for that block of sessions. And not only does it outline perhaps your approach, like some people write them more specifically, like session 1, 2, 3, or people may just have more of a collection of ideas, but it also helps us to allocate resources, because within your therapy plan, you're going to be writing down, okay, we've got 5 sessions for this block. We also need an NDIS report, and we also need a school OBS. So that's what a therapy plan is.
I think it's important for our own, like you said, allocation of resources and time, but it's also so important for families. Do you want to add a little bit about why we involve families when it comes to therapy planning?
I think just to make it really transparent of what exactly we're going to be doing, and often with goals that they want to work on, there's lots that goes into it. Long-term goals can span for 6 months to a year. So by outlining to them and working with them what they want in that block, I guess it almost like sets expectations as well, that the focus, for example, for this term might be sensory processing, whereas there might still be lots of skills that the child needs to look at, or I guess accommodations and resources that we can explore, but it just makes it really clear, I think, and gets their input. They're the expert in their child, which is important.
I really like how you mentioned focus. So I think we can't talk about therapy planning without pairing it with goal setting. And so whilst we're not going to dive too much into goal setting, we want to explain from our perspective what we mean when we're talking about focus and goals. So can we talk a little bit about what a long-term goal is, what a short-term goal is, and what those things mean and how they're related?
Yeah, so a long-term goal is like your overarching objective. I sometimes think of it a bit like an umbrella, but recently we've been chatting more, and Mick and I love this out of the COPM, is an OPP. So that's an occupational performance problem. And we're starting to write our long-term goals when it's linked like about an OPP, because we found that we were getting into spots sometimes, and I'm sure everyone's familiar with it, where your long-term goal might be like developing emotional reg. We could write that down for every person ever. So like why are we working on it? And it might be like, well, actually it's for Mick to engage in a full day of school. It's for Mick to be able to complete her afternoon routine. That's why emotional reg is important. So your OPP that we hope to use for the long-term goal sets an overarching objective for like give or take 12 months, right? Like it can be different for different kids. So please don't take that as something super specific, but your long-term goal is what you're anchoring to. So first we set the long-term goal. Then we have short-term goals underneath it, and they're sort of, we say like stepping stones.
Yep.
So it's those little steps that we need to take to reach that long-term goal. So let's take, for example, Mick completing her evening routine. And we then have a look at, well, what components would Mick need to build in order to complete that? And that alludes to what she was saying before about maybe it's bits of sensory processing, or potentially there might be some social stuff in there. That's where you really get into the like OT side of almost like task analysis of what do you need to help the person meet that goal. And if you anchor your long-term goal in an OPP, it's much easier to measure progress. So, I was going to say first, like your long-term goal, then your short-term goal, like your stepping stones, then comes your therapy plan. So we're almost talking about part 3.
I love that. And I think regardless of what like their OT language, but really performance problems or functional limitations or whatever you're working on with a child, it's kind of the same thing regardless of what discipline you are. It should be that you're helping the child to participate. Your goal should be function driven. So we're trying to move away from any sort of bottom up goals where you are just working on a goal for the sake of it, or because the NDIS has dictated a particular skill that they would like us to work on. So we've really kind of come back to our roots and we're really trying to define that. And as a bit of a shameless plug, we do have a booster on goal setting, which really fleshes that out, and some of the evidence around how long goals should be and those kinds of things, because we did look quite deeply into that. So if you're interested in more information about that, you can listen to another podcast episode or check out the booster. But when it comes to therapy planning, like you said, it's kind of how you're going to achieve your short-term goal or your more measurable outcome. So what to you is a good therapy plan?
It's a great question. I think a good therapy plan is one that's considered, again, I'm getting really OT here, like the PEO. I know we've been chatting a little bit more about this recently, but a therapy plan, I guess like in your face-to-face sessions, that's where you might be doing, for example, the upskilling of the child. Whereas, I think a good therapy plan also considers the other things that you can be doing as well for the family and the child that might not be in a face-to-face setting. A little bit like what Cowie said, the reports or education for parents or boosters or whatever it might be. I think it looks at the whole picture when you're addressing some of those shorter term goals.
I'm going to throw Mick under. She might not even remember saying this, but something that Mikayla said to me was like that good therapy planning is looking at the family, zooming out, and then thinking about it like you would a university case study. And I don't know if you remember saying that.
No, I'll take it.
But I've used that with a lot of people because I think in private practice we can get really bogged down on the face-to-face, and often families, when they are needing more support to understand how therapy works, they do just want us to – they want to come, they want to bring their kid, and they want the face-to-face service, and that's something that's hard to navigate in a fee-for-service model. But when Mick spoke about case study, it's really about zooming out and being like, in a perfect world, what would my approach be for this family? It would probably be a care team meeting. It would probably be a development of this resource or a home program. It may be a section of parent only sessions. It may be some direct therapy. It might be a school visit. So all of those things can be built into a therapy plan, and it gets the family on the same page.
Well, shout out to Monash University. There you go. That's straight from Monash, that one. So another thing that really makes a good therapy plan, and it's totally off the back of what you've said, but it's the allocation of resources. It is a good allocation. So we need to know what we have, what we need, and then what we can do. I'm sure we've all been in those positions where the family are like, oh, everything's important. I need them. It's social, emotional. It's the after school routine. It's this and this. And we're not disputing that all of that is important. But what I can tell you is these are the resources that we have at our disposal, whether that's we've got 5 sessions this term plus a parent coaching session plus this. Within that timeline we could realistically achieve. So it's also great for your sanity. So it's actually really think of your allocation of your resources. I also think a good therapy plan includes the therapeutic interventions or approaches. So I'll draw on mental health because that's sort of more fresh in my mind, that I might be like, oh, am I going to use CBT informed for this kid, or maybe am I thinking DBT informed? Should it be like structured, pretty flex? Like I'm thinking of all of those things as well to keep you on track, but obviously for good clinical care. And then the other thing that I'm thinking about is collaboration. Plus. When we speak about good therapy plans, something that is really helpful that we find as well is you're doing it with the family. Now you don't need to sit down and run through like, do you guys think I should do CBT or DBT? Sometimes that is indicated once you provide education on what those methods are. However, you can get the rough idea, speak about your rough sort of plan, see what they think, and then flesh it out once you sit down, because it's, as we all know, a different thing to chat about it and write it eloquently enough within your notes. So collaborative, and then also making sure that it is time bound. Again, it's not to make it like super crazy rigid, but it really is around this is going to be the plan for 4 months. And then obviously unless anything else comes up, we'll review then. And I should have mentioned a fundamental part for that collaboration is supporting the family to understand why you're doing what you're doing. I've got a little info sheet that we send out about this is what a long-term goal is, short-term goal, therapy plan, and their purpose. And that really helps people with that too. We've sort of accidentally trained people now. They come in, they're like, this is the long-term goal. I think this is what they might need to get there.
They're like, when's our therapy planning session?
Yeah,
we want a parent only.
Yeah, I have people email me and they're like, Caitlyn, it's booked in for in-person, but it's therapy planning. Let's change to Zoom. So it's hard to get started, but then, once you train people up, it's much easier.
What would you say to clinicians who are listening and thinking that just sounds way too rule bound? I just like to rock up each session and go with the flow.
Probably talking to two of the wrong people for that is probably the first part, is that I actually, and I swear by this, and I swear I've converted multiple people, in order to be flexible, you need to have a solid foundation. If you are being flexible without a solid foundation, you're just sort of doing whatevs and it's not really anchored by anything. So you do need to have a base knowledge and a base plan, I guess, in order to be flexy off of it. And I also would like to challenge you to try it for a little bit and see if it actually helps you to enjoy your job more, because you will not be scrambling before sessions anymore. You won't be like, oh, I wonder what they'll bring up this time, because you're so reactive. Because life happens, like stuff. I'm sure I could talk about something as well every fortnight that's happened that wasn't ideal, but is it related to what I came to this service to work on? Maybe not. So it actually helps you to be a lot less reactive, a lot less flighty, and I swear it will chill you out more, and then you can be more relaxed because you've actually got a strong anchor.
I was going to say, when supporting like the families, I think it helps them when you have a clear plan, see progress. I think when you're switching between different goals or you are being reactive, which we've all been there, but like it's a year then and you do a review and they're like, oh, we haven't made any progress. And it's like, what?
Or the progress they've made is literally just because they're a year older.
Yeah.
Yeah. Like it's not actually related to what you have been providing in therapy.
That's what I was going to say, similar to what Mick said. Like I think we think we're pivoting to meet the needs of the family and what they're bringing to the table, but more often than not, they get to the end of 6 months, 12 months, and they're the ones reporting that there's been no progress because you haven't got a joint plan.
Yeah.
So by letting them lead it too much, one, you're not actually doing your job, and two, it's not collaborative. So therefore it's not true family-centered practice, which we know we care a lot about the guidelines and actually meeting families where they're at, and clear communication is actually essential when we're supporting families. So I think I agree with Caitlyn. If you haven't been therapy planning, give it a go. It'll really increase the family's outcomes, but also your work satisfaction, I think.
And now you've got a well-rounded view on that, because Mick and I we're not fast and loose. Jack is fast and loose.
Fast and loose.
And
so if I say it's good,
it's good. It's got the round table approval. So get onto it. But I will not, it's obviously harder to start with like any new skill, but I swear.
Anytime
Great
that
decision.
I've been like, just not really sure like what I'm doing, it always comes back to, well, what's your goal? What's your therapy plan? And it's like, oh yeah, actually need to review it, and maybe we've come to the end of it, or the goal has sort of changed the priority. It's always coming back to that.
Yeah. And to, I guess, tie it to what we were speaking about in another episode on clinical reasoning, it's not a rigid thing. Like therapy is changing. We do need to use our clinical reasoning. So we can change what we're doing. It just needs to be in collaboration, and we need to reset the expectations. There needs to be, okay, well, yeah, we can work on that, but the next 5 sessions is going to look like A, B, and C. So I think it gives us a lot of flex in there to work with that.
For sure. I've had a kid where that actually just recently happened. We've just started school. The goal was around some real classic OT actually. It was a lot to do with fine motor, both in school and for some self-care. And then the family came in, and so we'd made our whole therapy plan on that, right? Like it was looking good. It looked polished. It was nice and like simple. I loved it. And then they come in and they're like, oh, schools had to like rip him off me in the morning. Like this is not going well at all. And so that's when but I've got my therapy plan there, and I say, all right, we had planned for the fine motor side. From what you're telling me, this sounds, I would say, more important, but what do you think? And like, yeah, I'd really like some help with this. And it's like, okay, we could start to chat about it in this session if you like, or we can go ahead with the plan that we had for today, which was some stuff to do with cutlery. And then our next session, or we can book in an extra, we can do parent only via Zoom. Let's get all the information, and then pending on how he's going, we can change our plan to pivot.
Collaborative.
So it actually puts you in a way better spot instead of then trying to like help this kid out with cutlery whilst I'm also talking over and being like, so how was that drop off? Tell me more. And then you've got like 3 goals and then on paper your goal is cutlery skills and every session note isn't lining up because you're talking about school drop off. It's no dramas. It's just you need your anchor in order to be flexible. Otherwise, it's just pretty random.
And that brings it back to the function, doesn't it? If we're constantly reacting to things, sometimes we're never working on the upskilling and the changing of the environment, and we're just being reactive to problems rather than those things that may be contributing to those said problems. So I think, pulling that apart is really important. Changing the recipe. As someone in the room might say.
Wasn't me. I got no idea what they're talking about.
You shall soon find out.
Yeah.
You got to elaborate. Go on, Mick.
Okay.
She's been dying.
If you listen to our clinical reasoning F, you would have heard all about it, but really it's about us being the chef and there's a recipe, and it's more than just having a list of strategies in your therapy plan about what you're going to do, because you might get a good outcome just by using some strategies. However, if you understand why things in a recipe go together, you will get a much better outcome and can share with the family why you did that so that they can then do that at home.
Great analogy, and explains why I am not a good chef. When I try to substitute. Yeah, in the kitchen, geez. I hope it's all right for the analogy. But yeah, I don't know when actually cooking how to substitute ingredients. And if I try, it's a shocker because I don't understand why I'm doing what I'm doing, whereas my boyfriend does.
Yes.
So that's why he is our resident chef. But I think like Jack said, just again with that therapy planning and like Mick with the recipe, the understanding allows you to be flexible, because I'm not saying that a therapy plan means you need to be rigid. It's the opposite. It would be really poor of me in that session that I just described if they came in, they're describing these horrific drop-offs and I'm like, did you bring the knife and fork though? You got that? I actually don't want to hear about it. I only want to hear about the fork use. That is not what we're saying at all. But now I am in a position to be dynamic, put those goals to the side and get something new going.
Any tips for clinicians who are nodding along and saying, yeah, I want to do this better? How could we help clinicians to unpack priorities with families?
I really like using the COPM, which is the Canadian Occupational Performance Measure.
Well done.
Remember?
Monash did do it
thank
right.
You. Yeah, I find some of these things that they actually taught us slowly start to creep back in when I thought maybe it wasn't as relevant. But that is helpful because I'm sure, or like with a lot of the clients we see, there is actually a lot of problems that come up, and often you do end up with a really long list. However, when they rate their satisfaction of, I guess, how satisfied they are with their performance, sometimes they don't care.
Yeah.
Like if they can't go to the toilet at the moment, it might not be the main priority. So I really like using
that.
Yeah. And I think with that, you can, that's probably a bit of an overstatement, but like you can work on everything, just not all at once. I can help you
Love
with
that.
everything that you've listed, just not all at once. So that's what I lean towards. And like Mick, I really rate the COPM with that stuff in terms of it just really showing where the priority area would lie, and as well with some of our self-rating scales to get the kids' input as well. That's usually how we pick. And if I know we're not talking too much about it, but if the family have a few long-term goals for say the 12 months, I ask them out of those, which one is the most important to them. Then we filter down to their short-term goals. Then we filter to the therapy plan.
Using the COPM as well, I find that it takes pressure off family having to identify what skills or what the therapy plan almost is.
Yes.
If we're including skills in a long-term goal, then it almost limits us in what we can do, or the family's like, I don't know what I want them to be able to do. So if you switch it to a task-based goal, then it's like pressure's off. You just tell me what's tricky at the moment and then we'll work on it. Like we'll figure it out together, and that's where you would further assess. But just starting with the goal and to, I guess, guide your therapy plan is a lot easier, I find.
I think that also is probably the most relevant for OTs because we are obsessed with participation. So we're trying to figure out where the priorities are. It may or may not be more complicated or easier for speechies, but I find they often write quite targeted goals already. I think they do, it might be certain sounds or it might be certain access to communication, or so they already, I guess, the function is communication. So I think they find this a little bit easier. But for OTs in particular, I think finding an actual functional goal can be a bit more like, swimming through the ocean sometimes a little bit. I guess, how do we balance having a clear therapy plan while allowing flexibility in terms of the family? So you already mentioned that a little bit with your example, but how do we go when families have varying access to therapy in terms of some may have 3 years worth of funding and others may come with a plan for 5 sessions? How do you use the flexibility of a therapy plan to address that?
It's actually easier, I would say, when you are really strictly time bound. I don't think it's great for outcomes. That's a different thing. But in terms of, let's say, your CDMP, that's 5 sessions. We need to have a think about how you would use that 5. And to be honest, it's probably different around how I would use the 5 if the 5 is part of your NDIS plan, because 5 sessions, and I'm sure we're all familiar with it, you get the CDMP and it's something huge. It's emotional dysregulation under the condition of ADHD. What does that even mean? They often don't list an occupational performance problem. That's our job. So that is where you honestly actually do have to be much more rigid, and you have to work under the Medicare guidelines. You're providing those 5 services under what you've been given. So there I find the most help is, which is hard, but it's trying not to get too stuck in thinking, well, of course 5 sessions isn't enough. I know that. We all know that. How are you going to use the 5 and under the guidelines you've got to work within? Like, for example, with the CDMP, the child has to be present. If I only had 5 sessions with someone, I would be going hard with parent, carer, education. How can I upskill them to be the OT? But I can't with the CDMP, so it's going to look different.
It's a really good point. Anything from you, Mick?
No, I think you put it in a nutshell really well.
Any risks or challenges further to the few things that we've discussed about if you just decide to proceed without a clear therapy plan?
Oh, really not much job satisfaction. I just think
we've been there, haven't we?
Yeah, I
It's
just
like-
think back to early on, because that's the other thing. Hopefully you're listening to the thing, oh yeah, therapy plan's good. Like how have they done it so well? Or I can't believe I've never done this. We did not used to do it. I want to make that very
Absolutely not.
clear. So I think that, and the job satisfaction just increases so much more. So a risk of not doing it is always feeling like you're scrambling. You get sort of 12 months down the line, you're like, what have you even done? And the outcomes are often poorer. If you've never therapy planned in your life and get killer outcomes, please shoot me an email. I want to know what you're doing and how you're doing it. But that's impressive. But a risk is poorer outcomes and you're not really enjoying your job as much. What would you
just
add?
high stress because like you said, you're always scrambling. You're like, what am I doing? And also in your sessions, I feel like you don't get a really in-depth understanding of, I guess, like a child's skills or a family's understanding in one area because you're always switching. So it's like, oh, we did work on regulation, but actually I don't really know if they can label their emotions because we only did it for a few sessions and then we switched to something else. And then also I think that has flow-ons into report writing becomes so much harder. It's like, what did we work on?
Actually,
what did
of
we
course,
do?
that's a great point. It is so much easier for us to write our reports, copy paste those goals and short-term goals and therapy plan over, speak to the progress. Another risk I would say is more to do with your clinician stress too, is running out of time for things that you didn't know were coming up because you didn't talk about them. I've got some families where they're like, oh, we're actually going away for 2 weeks in term, but we need this NDIS report here. Oh, and we also need this. That is where you're able to say, well, we have like 6 sessions in this block, for example. Sounds like we'll need to allocate 1 or 2 to this. We need to allocate 1 to this, and you're away for 2. So we're actually left with like then 1 face-to-face session. So what do you think that time would be best spent for? Obviously cancellations or whatever come up, but if you don't therapy plan, you're at risk of not accidentally over-allocating yourself work and under-resourcing yourself.
I think it gives like both parties a lot more control, which I guess then if you don't do it, less control. Not great for me.
Yeah, don't love that.
I know Mick said high stress, but I think sometimes it's also the opposite, like flat out boredom.
Yeah.
Like if families are coming and they're like, oh, they just really like coming to you and you're the only person they'll do handwriting with. I'm like, for me, feeling like a handwriting coach or a tutor is the biggest red flag to me that actually I'm no longer being a practitioner. I'm not providing intervention. I'm not providing assessment. I'm actually just being a coach.
A very expensive tutor.
Very expensive tutor to just provide the repetition that isn't happening elsewhere. So I think boredom as well, which is the opposite of stress, can also occur if we don't have a good therapy plan.
I love that. Both of us are like high stress and you're like, oh, I'm just not interested.
The only other
Not
thing
this
that
again.
comes to mind is even like almost, for lack of a better term, like misuse of funds. Like if you just keep going, a therapy plan can almost bring you to a point of reviewing and being like, can you actually discharge? And a lot of the time that's when you hear, yes, well, you don't want to lose you. This is so great. But you have that therapy plan to fall back on and say, well, we've actually done everything. And then you can move them on. So I think sometimes without it, you can continue for years.
That's a great one. So actually the risks also come down to the misuse of funds. So the ethical use of people's time and money.
Yeah.
I hope we've sold therapy planning. Sounds like an MLM. Like, so therapy planning for just $50 if you guys. No, but hopefully we've sold it well enough because there's like a lot of risks to not doing it. We would love for people to enjoy their job more, and that's certainly how it's helped us.
Absolutely.
And better outcomes. I should mention the client outcomes.
Better 100%. Have you guys got any practical tips for actually writing your own therapy plans?
Nick has a good one that we spoke about this morning.
PEO?
Yes.
Yeah, I've really enjoyed at the moment putting things into PEO because it can
Do you
help.
want to explain that for those that aren't OTs?
Yes, sorry. So P stands for person, E environment, O occupation. So when I write a plan, the things that come under the P would be more so around upskilling the child or the teenager, whoever it is, parents, whoever. E would be environment, so looking at what changes we can make to their space or bring things in, take things out. And O occupation would be making changes to the task specifically. I just find then you can add who's responsible for what, helps us all maintain accountability. And I also add it now into tick boxes so you can actually tick when you've done it so that when it is finished, then you can reassess and evaluate.
I think for the therapy planning, I always we do it at the start of your block of therapy. So that's an important part. It should be in every note that you do. So we have we just always copy previous note because it brings across long-term, short-term goals therapy plan, and then you write your regular notes. So I would be recommending doing that. And then another tip for success is when I talk about allocation of resources, I'm also chatting to the family about, do you think anything has gotten in the way of you implementing what we've chatted about? What can I do to help with the carryover? What do you think needs to be tweaked, if anything? So I'm also talking about that. So I would recommend doing that at the start as well. And I love, mixed tick boxes, because we're talking about like transferring it over to every note, you do get running progress when you do that.
It's really cool. And I love just how, I guess, by putting something so structured in place, it does create that flex. I think that it does cater to all types. I can confirm. We've got the people that love the structure, and we have the people that really like fast and loose approach to therapy, and it actually underpins both because it really refines your clinical reasoning as well. We can it provides tons of opportunity to actually think about your short-term goals and what is achievable, and you're setting something that you can achieve over 5 sessions, 10 sessions, and then your therapy plan just slots in there, and that's going to take a lot of practice over a long time.
Still practicing.
Everyone is still practicing, and we have so many conversations about it as a team. I think it's a really cool thing. So I think we might share a few links of the stuff that we spoke about around the goal setting tool. We'll put some information for the COPM. Whether you're an OT or not, you might find the structure of that useful. Any parting words for the listeners around what might be useful around therapy planning?
I think just remember that there's no one size fits all. Your therapy plan is probably going to look different for every client, even if they have the same problem come up.
And that the initial structure will actually give you flexibility.
Love it. Thanks for joining us.
Great.
Thanks,
Jack.
See you next time.
Bye.